Greetings and welcome to A1 Insights, the home for candid nursing conversations. Today, we welcome Mandy Pugh, a labor and delivery nurse, certified nurse midwife student, and chair of the A1 Rural Special Interest Group, the Rural SIG, and Teresa Horak, a nurse leader with almost 40 years of experience working in maternal care hospitals, levels 1 through 4, and chair of the Section Advisory Committee. You're in for a special treat because you'll hear firsthand about A1's first Rural Health Summit. I'm your host, Bria Anopise, and joined by Jamie Agunste, a perinatal nurse educator and 2022 A1 Emerging Leader. Jamie, I know for sure we're going to learn something new today, so take it away.
Hi, everybody. Thanks, Mandy and Teresa, for being here, and Bria, as always, for facilitating all of this. I'm really excited to have you both here today. I'm really excited to learn a little bit about what's it like to be a nurse in a rural community in New Jersey, where I work. We have almost 45 birthing hospitals, and we border Delaware, Pennsylvania, and New York, and can very easily cross a bridge to go to a lot of different facilities and hospitals for care if our patients need to. So I am definitely looking forward to learning a little bit more about what it might be like where you both work. So I was hoping that we could start off by having you give us some insight into what rural healthcare looks like in your communities and what it means to be a perinatal nurse in a rural community.
If I was to describe rural nursing, I would say we wear a lot of hats. That's the biggest difference is we have to have a very broad knowledge. I think our urban counterparts are definitely more specialized. We do, in one shift, we can do labor and delivery, nursery, postpartum, scrub a section, work in med surge, maybe, in the ER. And so we need to be very flexible. We are very team oriented because we are borrowing other team members from other units to help us in emergencies. And so in order to, meet standard of care, we borrow the house supervisor and, maybe some ER nurses. If our physicians aren't in-house, we might borrow the ER physician until they can get there. And so I think that is the biggest thing about rural nursing is that very flexible, very broad knowledge base. And I think that also we tend to be a little bit more autonomous because we do have to do so many things before the physician arrives on the scene. So a lot of times we, I think take charge a lot in situations just because we do need to respond before they're on scene,
Yeah, I think one of the other differences probably is just often the distance that some of our hospitals are from, smaller hospitals are from the larger hospitals. We have a number of critical access hospitals in Iowa where we do still have deliveries. But we've also had 43 hospitals closed since 2000. So there are large spaces where there just is nobody for a long way around. So if you're, one of our critical access hospitals is 70 miles from the nearest hospital of any size next to it. And that's around also into Missouri and, even into Iowa. So when you are in those hospitals, whatever comes through your door, you have to be ready for and they have to be ready for. And then I think the other piece of this that's probably worth thinking about and considering is the our EMS partners also have to get involved in those situations if the patient has to be transferred. And sometimes they're not super comfortable with obstetrics. It's not their forte. They don't really want to birth babies.
I'm shocked.
I know, right? They don't want to birth babies. So, if we are in one of our smaller facilities, the labor nurse sometimes then ends up getting into the ambulance to get the patient to a higher level of care if that's needed. So then, if we've only got a couple of them in the house, then one of them is on the rig then on the way to the hospital. And it's the nurse and the patient for the next however many hours it takes to get, sometimes it's 2.5 hours by ambulance ride to get to the next place. depending on where you're going and what you need. So there's a lot of expertise that I think gets taken for granted with a lot of our rural nurses because they are really having to do stuff that I don't know that some of the level 4 nurses that don't leave their facility ever really experience.
Wow, that's a really interesting perspective. Can you tell me what is a critical access hospital for people who don't know or have had no exposure to something like that?
Yeah, so a critical access hospital is a level 1 hospital. They're able to do, all the good things that we need to do for a normal birth. They wouldn't have an intensive care nurse or NICU of any sort or available, or they may not have, in Iowa, lots of our hospitals don't have obstetricians. They just have family medicine, well, don't just, they have family medicine doctors that provide the care for their patients. And sometimes those family medicine doctors do C-sections. Sometimes a general surgeon does a C-section. But there are not a lot of OB doctors per capita in Iowa. So we have a lot of mid-level, a lot of midwives and a lot of family medicine doctors that also do obstetrics in our smaller facilities.
So it sounds like it's like an all hands on deck situation, from what both of you are saying, and that it's much more interdisciplinary, I think, than what people who work in more human resource accessible places would be, right? Like, around here, I mean, if I drove for 2.5 hours, I would be blowing past probably 40 hospitals and I would be like 3 states away. So it's really interesting to think, that you might have to put somebody in an ambulance. It also sounds like there's probably like situations if you have a critical access hospital where, somebody gives birth and the baby needs to be transferred, like there could be, and the mom is maybe really sick, like maybe there's a separation, a really significant distance separation. Is that accurate?
That's absolutely
very
accurate.
accurate.
And I'm sorry, Teresa, go ahead.
Good.
We try our best. I mean, the best case scenario is to transfer that mom still pregnant so that she is not, separated from her baby because of that distance. But, yeah, it's very difficult for these moms when, they're, you want to be up there, you want to be breastfeeding, you want to be doing all the things, and, you're 2 hours away. So, yeah, the best case scenario is to transfer them still pregnant, but it's not always possible.
No, we definitely know situations where when they're going to give birth, they're going to give birth, and you don't want them to do it in an ambulance if they're not stable, right?
And I think the other piece of this is that there's a lot of in the hospitals that have closed because of the distance between hospitals. Even though they don't do obstetrics anymore and they may not even have a fetal monitor anymore, patients are still delivering in their emergency rooms because that's the closest thing. So there's, they even though they don't technically do OB, sometimes they still have to do more OB than they would wish just because they're the only thing for a long ways too, which, that's a whole other can of worms if they're no longer have all the obstetric things that they had when they were a birthing or delivering hospital, but now they're still having deliveries. It's just that's a challenge.
There are some rural facilities that do have OB units. I have learned since I've, been the special interest group chair, the rural special interest group chair, that don't have central monitoring. They have OB units, but they don't have central monitors. And, that's a whole nother aspect to think about, how they have to, keep up with that monitor and are doing so many other things at the same time. So, that's a whole nother aspect as well.
It's really interesting. I've never been in a situation where we haven't had something like that. You take it for granted. I think you take it for granted if you just assume that you're going to have always all the equipment and the team, that the team's present. So you've already brought it up a little bit, but can you, we're hearing a lot about rural health, right? We're talking a lot about maternal mortality in rural areas. We're talking about accessibility to care, closure of not just hospitals, but hospitals are still standing, but their OB units are closing. Can you talk about some of these pressing issues that are facing rural communities and nursing and perinatal units and everything in your areas?
Yeah, and I think patient access is a huge topic for, and because if happen to be a socioeconomically challenged birthing person and you maybe don't have gas money and you don't have, great transportation, trying to even get to, a facility for prenatal care becomes challenging. Trying to get someplace for delivery becomes more challenging. There's kind of a whole kind of cascade of things that happens when patients have those challenges, and the farther away we get, the worse that becomes because it's harder and harder. If your car isn't very reliable and you're somewhere that's a long distance from a facility that provides either prenatal care or delivery, just even, just those basics are really difficult to come by.
Well, and what you were talking about, keeping facilities open. I mean, that financial strain that's on these facilities, I think the biggest thing is reimbursement. If you're considered a rural health clinic, you do get extra reimbursement from Medicaid and things like that. If you're a private physician in a rural area, I mean, your reimbursement is significantly less if you're in private practice. So that is very difficult for physicians coming in, and it's hard to get physicians to come to small areas, and definitely if they want to be in private practice and have more personal say in the care that they provide instead of working for a hospital, it's a huge challenge. And I think Medicaid reimbursement is because most of your patients that you take care of in rural areas, there's a lot of socioeconomic challenges, and so their majority are on Medicaid, and the reimbursement is just not that great. So you are not making a whole lot of money for your facility, even though we try to argue that women, generally make the healthcare decisions for their family. And so we try to argue that, if they have a great experience coming into the hospital, then in turn they're going to bring their families to the hospital and they're going to bring more customers in. But it's still a challenge to justify keeping the unit open when hospitals are having to make cutbacks. We are definitely the lowest moneymaker if we are primarily a Medicaid population.
So then where where do the nurses go? Like if their unit closes, what does it look like? If you can speak to that, even like what is next for those nurses? What are the opportunities for them and their families? Obviously, they have to stay employed, right?
Well, you change specialties mostly. If you can't make it to another OB unit, if it's not near, you're going to be changing specialties. So, we're losing labor and delivery nurses as well. So, yeah.
Oh my God, it makes me so sad. Yeah, because like people who do this work, for the most part, like we love it, right? Like there's something that just like your soul needs this work for those of us who do it or who have done it. And to think of like giving that up, being forced to give that up because your facility is closing or whatever is must be really heartbreaking for all of the teams, not just the nurses, but for providers, especially if you might have doctors who moved into that area specifically to do that work, and then and then the unit closes. Yeah.
The alternative then is that you drive a long way to come to work. There are some people that work with me that work
right?
that they'll drive 90 minutes to come to work. So, there's some people doing some pretty long, and that's no traffic. That's not sitting in traffic. That's just straight, 90 minutes drive on the highway. So,
well, and that's like after a night shift too. I mean, my drive, I remember, I worked all exclusively nights when I did labor, and I had a maybe 35-minute drive, like max, with traffic coming home. I drove to the wrong house one time. Like I had moved and I drove to my old house, And I pulled into the driveway and I was like, whose car is that in my driveway? And I was like, I don't live here anymore. I mean, I think for me, thank God we hadn't moved too far away from there, because I was really not in a position to be on the road too much longer. And I can't imagine having to, try and stay awake after that long of a shift and being that exhausted, like that just bone numbing tiredness, and to have to drive like that distance. It's a safety issue for sure. Wow. What do you think are some of the myths that you want to dispel about rural healthcare and rural communities and the service that you provide?
Yeah, I definitely think, or I don't know if Teresa, if you want to take this, whichever it's.
Mandy, you've got some thoughts on this one. I'll let you take this one.
Okay. Well, I do think that people believe that they can't get quality care in rural communities. I think that's the biggest myth. I, I've worked in both urban and rural facilities, and I've chosen to work in more rural facilities because, and I think that there's pros and to both sides of it. I have enjoyed working in both, but I do love that I have been able to provide a little bit more personalized care to my patients in the rural setting because I know them. I know them. I go to church with them. I see them at Walmart. I watch their families grow up and watch them blossom into mothers when they thought they could never do such a thing. And so in that way, I feel like we are able to be a little bit more personalized in that approach. And so I think, and also, well, in my facility personally, we deliver like 35 babies a month. So I have been able to, take a little bit more time with my patients and do that extra fluff, because of the staffing ratios in that area. So I can't speak to every, rural facility, but that would be my answer to that question, is that I feel like people feel like they can't get quality care in a rural setting when I chose to go there because I'm able to spend more time, and so I feel like I'm able to give more quality care in that setting. But I mean, I'm sure there's urban facilities everywhere that's the same. It's the same on both ends, so but that is the biggest myth, I think, is that you're unable to get that quality care in a rural setting. So
I love that. I like teared up a little bit because I think that, the fact that you have this passion for this particular work and that it's hard, and you're not like walking towards it, because I see you online and I see the work that you do, and like you pop up in like the New Jersey section Facebook page promoting things, and I'm like, I love this girl, like she's awesome, because I think that you seem to have found your niche, and you have found something that's hard, and you're not like walking towards it, like you are running towards it and embracing the hard. And I think that is, it's awesome. And as somebody who worked at a really, really busy facility, like we would do 30 babies in a day or two, right? Like, and yeah, it's wild. Like I remember, I think a really, really busy night shift was, I don't know, 15, like 18 babies. You just feel like they're popping out everywhere, right? It's like, you get a baby, everybody gets a baby. Yeah. And it's just,
well, and I think,
and that's, sometimes it feels like where you can't, provide the personalized care that you want to, just because sometimes like you don't know what the night is going to look like, even because of the volume, right? And even when you're like fully staffed and everything is like aligned beautifully, sometimes you just get those nights, right? And it's wild. Like the thought of doing 30 babies in a month is
and I
like,
think that you've touched on, I mean, the biggest issue with all the maternal deserts and all the small facilities shutting down, all that volume is going to the urban facilities.
gotta go somewhere.
It's going to the urban facilities. So you are not able to provide that specialized care that you are so good at because you are just overwhelmed with the additional volume from these hospitals that would have cared for those patients had they stayed open. And so we are not, with that issue, we are not allowing urban facilities to function at what they do best, I think, because they are inundated with everybody.
Yeah.
So I think, you know, and I know people look at rural obstetrics as hard, but also, you get so, it's whatever you get used to, you like I've worked in rural settings. I don't see it as hard. Like, I mean, if I can't, I mean, we work with these people all the time. We live with them. So I know where you live. I'll send the police to your house to go pick you up if we can't get you in. We know that all the police in our community, like you know what I mean?
Wow.
Like, it's what you get used to it, and you build. And I think, and I know I keep talking. I'm so passionate about this, but
Keep going. We'll get to Teresa.
Yeah,
keep going. Finish your thought. It's okay.
We don't speak about our realities as rural nursing. And I mean, I go to all the conventions. I go to all the AWHONN conventions, and I learn something every time I go. I learn something, but you don't tend to, well, it's difficult to take that and apply it to your small setting with less resources and less staff. You learn how they function at an urban level. You learn, and everyone is communicating and collaborating, and you're like, oh, that's how you do it at your hospital. Oh, let's do it at my hospital and everything. But as a rural nurse, because people are just, most urban nurses are like, I can't, how do you function that way? How do you function with no, you don't have your OB in-house 24/7? How do you function without, your surgical staff? And so you don't tend to speak your truth. You don't speak up when you're in that setting. And that's what makes the summit so great, is because it's going to be a group of rural nurses where we are in a judgment-free zone, and we can speak, and so we can collaborate. And that's the best thing about conference. That's the best thing about AWHONN, is that you meet similar creatures. And so you can like say, oh, you do it that way. I can take it to my facility and improve our practice because I've never thought about that. I've never thought about to do it that way. And so if you get people who work similarly together, I think that you can improve best practice, because you start those conversations, you plant a seed and take that back and build on it, and I've kind of gone way off topic, but that's
No. I'm loving it. We're going to stick with this. And then I'm going to jump to Teresa in a minute, but I feel like, okay, so maybe I just did like stereotype, right? Because I was like, oh, well, it's so hard and you're running towards the hard stuff. And you're like, this is every day, right? Like, do you feel like it's maybe that's an assumption that I made, that like, it is really hard all of the time. Like, and what you're saying is it's not, I don't know. Fix me here.
It's I mean, like I said, we tend to practice a little more autonomously. I mean, so say we have, I mean, I've had locum pediatricians who have come in, to, on the weekend to take care of newborns, for example. And when we've had a baby who is misbehaving, needing that extra care, they're kind of like a little shocked because we just start doing all the things, and they come in and we've already got the blood work drawn, the IV started, the chest x-ray done, all the things. So it's like they can come in and just, okay, let's move on. You know what I mean? So it's a different, I'm definitely not saying that we practice out of our scope. We have kind of protocols in place where, you do those things, but it is kind of a shock for someone coming outside and they're like, oh, you've already got all the stuff done. Okay, we can just take that next step, and so yeah, you just you get used to your situation, and you just do things a little differently.
So you have to be, so maybe what I'm hearing you say is like, you're obviously still functioning within your scope of practice as a nurse, but it just looks a little different than it might look in other settings out of necessity.
Out of necessity.
Yeah.
And you're constantly talking to the doctor on the phone as they're driving, on the way, and they're telling you, okay, let's do this. And so you're doing those things as they're driving on the, and, if your physician isn't in-house and you need them, you need to deliver. You can always call your ER physician up. So there are those backup plans in place that, we utilize.
Teresa, do you have anything to add to that?
Well, I was just thinking about your comment about, being hard. I think it can be amazing and hard at all levels, right?
Right.
I think every single level of hospital has its own set of challenges, and honestly, what we do every day is amazing, and can also be really hard. So it's both, I think, and I don't think it necessarily depends on. I think it's different necessarily, but I don't know. I think there's challenges at every single level of care.
Well,
yeah.
And this is just an example. And I know this is a hard topic for people to discuss, but I think it's important to discuss things like this. It's always a question of, and I saw a thread one time on Labor and Delivery Nurses Rock, which I find that social media is such a great way to connect. But there was a rural nurse who got on and started a thread, say, hey, I work at a level 1 facility. What is your protocol that you use when you need to cut immediately? You need to do a C-section. Your baby is in distress. Anesthesia is not there yet. What do you do in that situation? What's your protocol? And half of the nurses responded similarly to how I know things have been done in, the rural facilities that I've worked at, where you have a kit and it has Marcaine, lidocaine, you just numb and cut. Now, granted, that is a rare occurrence. I have seen that happen twice in 27 years. It's necessary, but horrific all at the same time. And, but in this same thread, there were other nurses that responded that said, hey, our house supervisor is certified in IV sedation. And so they come in and they give additional medications that can sedate that mom, while you're numbing and cutting. And then some other people came in and they said, oh, we had the ER physician come in and intubate, manage the airway until anesthesia can come in. And I can tell you that I was reading that thread going, I can't believe we've never thought of that. Why have we never thought about that? And I know other facilities, same thing. Like I said, half the people responded the same way that I knew, that they just have a kit and they just numb and cut. And so those are the conversations that can be had at the summit coming up. We can have those conversations where how have we never thought about that? And so we changed our practice at our facility after I read that thread. We changed that practice. We now have had discussions with our ER physicians. They're like, absolutely, we can do that. Absolutely. We can come up and do that. And, some people will argue, the ER physician can't leave the ER in those kind of situations. But at the same time, like at our facility, the ER physicians leave the ER when you have a code called in med-surg. So they do leave briefly for those kinds of situations. So that's how we could justify it at our facility, because we're like, it is a code. I mean, basically
And that I would say that that's pretty, I think that even a lot of the larger hospitals, around, well, large or small, you have a team and not everybody, like labor and delivery should not be so isolated where other people are not coming in to bring their expertise when it's absolutely necessary, right? Like, the RRTs, the code teams, like those are multidisciplinary, I would say in a lot of these facilities. All right, Mandy is chomping at the bit to talk about the Rural Summit. So we're going to go there, okay? But I'm going to start with Teresa. So just to talk about this real fast, AWHONN is offering its very first one-of-a-kind conference called the AWHONN Rural Health Summit, and it's happening this fall. I've been seeing it on social media, and I'm like really excited for all of you and for those people who are going to get to attend, because I didn't even think about, Mandy, what you just said about these conferences where you come and you learn all these awesome things, but it's really different to try and implement it into your specific, practices and facilities that have different needs by nature. So the AWHONN Rural Health Summit is going to be offered in Des Moines, Iowa on October 6th and 7th. There is going to be a virtual option, and Bria is going to post in the show notes where you can find it, but you can just go to the AWHONN events page, but she's going to post some information about it in case you're interested afterwards. Teresa, can you tell us a little bit about the summit, who came up with the idea, where it originated, and just what people will learn and see and be able to do if they attend either in person or virtually?
Sure. So it really started with conversation with the District 4 group of the Section Advisory Committee, and that we have the leaders from Iowa, Nebraska, Kansas, Minnesota, North Dakota, South Dakota. So all of our states are pretty, I hope I didn't miss anybody. Nebraska, let's see. Yeah, I think I got it.
Did you say Iowa?
Oh, well, Iowa, yeah.
Yeah.
All of our states have really pretty rural focus, and we were talking about some of the differences that Mandy's pointed out and how to highlight, reach, and sort of address the needs that maybe might be unique to folks that are in the states that we all serve. And so we started talking about doing this summit, and we brought our friends in from AWHONN, and then Mandy got rolled into the planning, and it kind of has rolled from there. There's an amazing dedicated team that not only is planning their state conferences, but has been working on this Rural Health Summit for over a year now to bring it to fruition. So there's been a ton of volunteer work by a lot of really great people trying to kind of having a vision of what this could look like. So we've got some pretty great speakers. Rose Horton, who's our chair or president, is going to start it off. And we've got all kinds of different topics that are specific to rural health. So it's going to be pretty. I think it'll be it's geared to, as Mandy said, geared to folks that do practice in more rural settings, but it's also geared to people who get transfers from the rural settings, because I think it's always important when you live at a higher level hospital and somebody's coming to you that you have some understanding maybe of what it looks like maybe to be in a size facility that Mandy's been talking about, and all the innovative things they have to do to even get the patient to us. So I think it's going to create some synergy maybe from all sizes of hospitals to come together and really think about our folks that live in rural settings and how to really highlight what they need. And there's a lot of innovation that I think people will hear. We do have a group that's coming from a hospital where their OB unit closed and kept services locally. We have a speaker from South Dakota that's talking about getting doulas paid by Medicaid so that the doulas could help maybe stand in the gap a little bit. We've got saw a speaker talking about how a larger hospital helped one of the rural facilities because, as Mandy said, when somebody delivers 35 deliveries a month, trying to get new nurses oriented is a deal. And so how to, get enough, repetition and experience so that they feel comfortable, doing obstetric services at their local hospital. Sometimes they created a partnership to work on that. So
That is so cool.
yeah, so there's a lot of different kind of innovative things that lots of amazing people have done to kind of work in this sphere.
Yeah, let me tell you, that District 4 is like a powerhouse. They have, and they're passionate about it. It has been such a privilege to be a part of that and watching them, respond to the needs of their community. They have, man, this convention has just been pulled together. I mean, just a lot of great minds putting everything into it. So it's been a privilege to be a part of it.
So how did you get pulled into it? Tell us about the rural SIG. Tell us what the SIGs are.
So AWHONN has special, which I have been so excited to be part of what AWHONN is doing recently. They have, I think that Jonathan Webb, he has really made a special interest into including a diverse group within AWHONN and recognizing different areas. So there's all kinds of special interest group where people can find similar interests and connect. And so that's how the Rural Special Interest Group was started, is to bring rural nurses together. And then, we have a hub, as I'm sure that where people can get online. AWHONN members who are rural can get online and connect and ask questions and things like that. And then it has expanded now to a focus where we can now have a convention, for rural obstetrics. So that has been exciting, because when I started in AWHONN years ago, there wasn't anything like this. So it's definitely been a nice thing to see progress. And one challenge though, and I don't know how a lot of rural nurses are not AWHONN members. And so it's difficult to find them and connect with them and bring them in, which I think is a social. Everyone is on social media. So I have created a group called iRoar. It's Improving Rural Obstetrics Through Advocacy and Readiness. And so my vision is to find those rural nurses and create a little village there, and then in turn bring them into their professional bring them into AWHONN, that way, because it's so difficult to connect with rural nurses, I think, sometimes. And there's so many. Go ahead. And sorry.
No, that's okay. I think that I just want to kind of jump on that point a little bit, because I think that sometimes with like conferences and conventions and the topics that get presented and all of that, like, is it chicken or the egg kind of thing, right? Like if there's not enough interest in something, not that there's not enough interest, but like you have to have enough people that want to come like see something and learn about something in order to, kind of put it on a platform or on an agenda, right? And if you don't have enough people that are members that know to submit something, then the organization or organizations aren't going to know the level of interest. Am I making sense there? So it's kind of like, how do you get it rolling?
Find topics that are for those people. How do you? Right. Absolutely. And that is like a huge thing. People, which I have learned, and hesitantly, I know that I drive Teresa crazy, because people are like, you should speak or you should do this. And I can tell you, I am now in this kind of thing where it's like a group of people talking, I feel much more comfortable. And I am extremely extroverted, but I will not speak in front of a group. Absolutely not. It terrifies me. But I know that there are rural nurses out there who have that gift, and they want to be, that would fill their cup to be a leader in that way. And so I am making myself very uncomfortable and
Yeah.
trying to find those people so that I cannot have to do it. But you know what I mean? Like there are those rural
You're trying to push
leaders,
yourself out of a gig.
there are those rural
I
leaders
love
out there that would
Yeah.
be great at it, and just finding them and I think A1's great at mentoring. I mean, they are. I mean, like the emerging leaders and all the things. And so finding those people and supporting them and pushing them to do what would fill their cup, you know. So
Well, it's like, and Teresa, maybe you can comment on this. Like it's legacy, it's like creating a legacy, and it's also succession planning and all of that, like what Mandy was just talking about, right? Like mentorship and all of that. Can you add anything to that? Because I know that you've had a long and storied career, and I'm sure you've mentored a lot of people in your time.
Yeah, I mean, like Mandy said, it's they're getting people into the spaces where they can grow.
Yeah.
This team has, I think, stretched themselves a lot, doing a lot of different things. Some of our speakers are actually some of the District 4 folks who've done some amazing things in their own careers, and I don't think many of them have not spoken at a national conference before, but this is their, new platform. They've spoken, but not maybe at a national conference. So, they're just within the team where I've seen a lot of, kind of growth and posts making it into some new spaces they might not have been in before. So.
yeah. Well, I know one of the speakers that's going to be at our rural conference. She is a manager at a level 1 facility, and Michelle Sands, and she was instrumental in getting the doula, Medicaid covering doula services in her state. I was completely inspired by that as a rural nurse. I'm like, gosh, I've never even thought, could I affect change on a state level, national level, that kind of thing. And she completely did that. And I think that she can be an inspiration to other rural nurses, in the same way. So,
I love that. And I love that you're, kind of pushing past your comfort zone. It's not easy to do. Like I remember the first time I spoke at the national convention was in Phoenix, and I spoke twice, and they were two very big rooms, and I had my Aura ring on, and I don't know if you know what the Aura ring is, but it like tracks your heartbeat from like beat to beat. It's like fetal monitoring around your finger. And I went and looked at it later, and you could see the spikes like during the time that I was speaking. It was up to like 140 beats per minute for like sustained for a good like 15 minutes. I know. And I think that, I still get scared every time I get up there, and I think you just have to push past it, right? Because it's you're putting yourself out there as like model, like if I can do it, you can do it, kind of thing. I don't know.
it definitely inspires other people, I think. Yes, who might want to do the
Yeah,
same.
yeah, yeah. They have to be able to see themselves kind of in the work that everybody else is doing. I wanted to start wrapping it up, but I want to end on like a really, really good note. So, we've talked about some of the challenges of, of the work that you all have to do. What are some of like the best parts of your job and some of the most rewarding aspects? And I'm going to start with Teresa, if that's okay.
Um, gosh, there's so many that are wonderful pieces of the job. The people that you're around always are the best. I mean, I wouldn't survive life, and I don't think most of my nurse colleagues would say the same thing. We wouldn't survive our lives without our circle of people that supports us and does all the things that we do. But, it's always been about creating kind of the best patient care for people for me, and creating something that our nurses feel great about that then transcends into making the patients have an absolutely amazing, experience, both, with prenatal care and with their delivery, and then in postpartum, and kind of all through the course of their trajectory into, that becoming a mom, which is, we get people who are, come in as a couple sometimes and they leave as a family. And that is a unique space that nobody occupies but us. And I have loved that my whole life, and I still do.
I love that. I always try to remind myself that, that regardless of like kind of what happened, because in our spaces, in the birth space, things don't always they don't always end up happy. Right. And I think that, I always reminded myself that like, I have the ability to become part of the story of this family, regardless of what happens. Right. And to me, that was such like a sacred space to walk into and to occupy, because that they will tell that story to their family, to their friends, to the baby, and like you're part of it and you have the opportunity to impact that. And like how cool that we got to do that, right? Like in our lives. So Mandy, what about you? What do you have to add that's, uplifting or cool about your role?
A similar thing. I mean, like I love, well, I choose to work in a rural space because I see those families over and over, and I'm now delivering the babies that I delivered 20 years ago, which is awesome to see that whole circle.
Multi-generational families is what I'm hearing you say, right? Yeah, that's awesome. And you have the opportunity to impact that. That's so cool. As we wrap up, did either of you have anything else that I didn't ask that you wanted to add?
I don't think so.
Come to the summit, everybody.
To the summit.
And it's so funny. Come to the summit. It's so funny because I want to go to the summit so bad. I'm going to have serious FOMO, even though I don't work in a rural setting and I'm not even at the bedside anymore, guys. But it's funny because there is a lot to relate to regardless of where you're located. And I think that what we know about, labor units and healthcare in general, everybody is really challenged right now. And, in New Jersey, like I said, we have all of these hospitals, but we are also experiencing, issues where these units are starting to close. And in the southern part of our state, we've lost at least 2 units, and we have several counties now that are without birthing facilities. And so these families have to travel for longer to find, to gain access to care. So this is happening everywhere. It might not be considered a desert, but it's low access, right? And so what you are, what you're learning and teaching everybody really is about personalized care and specialized care and nursing innovation. And finding ways to kind of come together and learn from each other and all of that. So I love what you are doing. I have learned so much today, and I really appreciate you taking the time to kind of describe to those of us who don't work in a setting similar to yours, like what a day in the life might look like, and some of the things that you are going through and all of the awesome things that you're doing. So thank you for your continued work. Come to the summit. If you're watching this and you're not an AWHONN member, join us in all of this awesome work that we're doing. And thanks, everybody. Bria, I'm going to turn it over to you.
Thank you all so much. Before I close, I want to give Teresa some flowers because she was selected as an AWHONN Fellow in 2024. And she is this year's recipient of the AWHONN Award for Excellence in Leadership. So I wanted to say thank you for all your dedicated years of service before we got off of this podcast.
Thank you.
Absolutely.
Thank you so much.
And to you and to Mandy, thank you for sharing how passionate, flexible, adaptable rural health nurses are. And you all shared that you do have solutions for other rural health nurses, for other healthcare practitioners, and for people in your community. I love how you highlighted that. And so we're excited about the summit, that you all have this cluster to share your innovative ideas across different states. So we want our listeners to come back to our podcast at awhon.org/podcast, read your bios, get connected with you at the Rural Health Summit or through social media now that we know you're both active online. I'll have the link in the show notes. We ask that you subscribe to follow AWHONN on Apple, Spotify, YouTube. Tell a friend and bring a friend with you to the summit. So everyone, stay safe. Thank you again for your time, and we'll talk soon.